So first of all, I would like to thank Dr. Nitin and Gripma for giving me an opportunity to present this topic, how to manage anemia in the peri-surgical setting. The first thing he asked me, what do you like to present? I said lap splenectomy, because as surgeons, हमारा दिमाग वहीं चलता है. So we would present something surgical. But yes, he told me that this topic is going to be of mass interest to many people who are doing surgeries, including gynecologists, neurosurgeons, and other surgical specialties. So thank you, Dr. Nitin, for guiding me. So why this topic? Anemia is generally reported, as also told by ma'am, that it is present in about 10% to 50% of the patients in the preoperative setting and as much as 90% of the patients in the postoperative setting. Timely detection of anemia prior to high blood loss surgeries can allow clinicians to manage it and optimize hemoglobin level, making patients better prepared for the surgery. So the onus is not only on the surgeons, or we cannot say that okay, the patient was not being given fitness by anesthetist, but we have to prepare the patient from the beginning. So the problem is availability of allogenic blood transfusion has arguably contributed to a false sense of security among the clinicians. We always say, okay, hemoglobin is less, we'll arrange few blood transfusion for the surgery and let's see how you respond after the surgery. But this is not the case. You should not have a false sense of security with the availability of blood in your hospital, and it should never be considered as a default treatment for anemia in the perioperative setting. So anemia in perioperative setting is a serious problem. The problem of poor oxygen delivery, the problem of risk of cardiovascular complications, the problem of opportunistic infections because of the low immunity, the problem of bleeding and coagulation issues, as there is increased risk of perioperative bleeding and dilutional coagulopathy, the problem of length of hospital stay. If your patient is not good, he is having anemia, there is delayed wound healing, prolonged recovery, and increase in the healthcare costs also. A problem of excessive transfusion needs and increase in morbidity and mortality because of all the above factors. So you should always screen your patients as soon as they present to you in your OPD as a surgeon, even if they are being directly coming to you or being referred. Again, these are the factors which can cause anemia in your patients. So anemia screening starts in your OPD and it should be at least started at least 4 weeks ahead of a planned surgery. If the surgery is not planned, it's an emergency surgery, then also you should look at the factors why the patient is having anemia or a hemoglobin level of less than 13 gram per deciliter. You should always evaluate as a first step with iron status. Use either transferrin saturation or reticulocyte hemoglobin concentration, and they can fall into two categories. If the transferrin saturation is less than 20%, then you can say that the patient is having iron deficiency anemia and you can start with iron therapy. If you have time, that is, you have 4 weeks before surgery, you can initiate with oral iron therapy. If you don't have time, you can initiate with IV iron therapy under evaluation with the help of your physicians. So, but if the transferrin saturation is more than 20% or the reticulocyte hemoglobin concentration is greater than 30 picograms, then you should evaluate serum creatinine or GFR ratio. And if it is increased, then the abnormal value of serum creatinine or GFR ratio is there, then you can say that the patient is having a chronic kidney disease and you should always consult a nephrologist for the same. And you evaluate vitamin B12 and folic acid. If this is decreased, then you should supplement B12 and folic acid accordingly. So once you start with iron therapy, you should always see whether there is a response to iron therapy or not. And the normal, you should always reevaluate if there is no response, the vitamin B and folic acid level, and you should always ensure again that there is normal serum creatinine or GFR. If there is no response, then you can say that the patient is having anemia of inflammation and you should initiate erythropoietin stimulating agent. Consider referring the patient to the hematologist who will rule out hematological malignancies and myelodysplastic syndromes, and consider iron therapy for functional iron deficiency. So in all possibilities, the goal for a surgeon is to normalize anemia, correct iron by IV therapy if you cannot or do not want to delay the surgery, maintain a broader state of mind to evaluate and manage patient even in the post-operative period to stabilize the hemoglobin level during recovery phase, as many patients, especially the GI patients, make them prone to nutritional deficiencies because they are not able to eat properly in the post-operative phase. This will cause worsening of the anemia because of poor oral intake. and this directly impacts the wound healing and recovery, with delay in starting of the adjuvant therapy if needed for the patient, regardless of a wonderful surgery. So the conclusion remains: anemia should be screened for, properly diagnosed and treated. Treatment of anemia should be guided by the etiology of the anemia as per the flow chart. The anemia management strategy should be tailored according to individual need of the patients, and perioperative blood loss should be minimized. There are methods called as cell salvage method or autologous transfusion. If you are well versed with, or if the facilities are available, you can adapt that. Transfusion as a default treatment is often not appropriate management of the anemia. Remember that the management of anemia does not end with surgery. Anemia remains a significant and a common problem in the perioperative and the postoperative setting. And anemia is not an innocent bystander, and its presence, particularly in the perioperative setting, should never be ignored to get a better surgical outcome. Thank you.